So, let's look at what our current, guidelines tell us, our current treatment paradigms. How do you, Dr. Daneshmand, approach a patient with intermediate risk non-muscle invasive bladder cancer?
Yeah, so for intermediate risk, the AUA guidelines recommend either chemotherapy or immunotherapy, really BCG. But in the era of BCG shortage, I think most of us are recommending as standard of care a course of chemotherapy, and we're sort of getting away from use of mitomycin and moving towards gemcitabine because of the lower side effect profile. So I would say current standard of care for intermediate risk would be intravesical chemotherapy induction plus minus maintenance therapy thereafter. Some people still use BCG, particularly for high grade, as you said. If I have a high grade tumor, I will probably want to use BCG for that patient and maintenance if possible. But mostly I'm using GEM.
GEM. And you're doing like upfront 6 induction, like once weekly,
yeah.
And then do a monthly maintenance?
Monthly maintenance, yeah, for about a year.
Similar in Chicago?
Well, I'll tell you honest, I'm probably an outlier here. I actually, a lot of these patients with intermediate risk, if they've demonstrated some stability, meaning they're not recurring at every 3 months, after a few resections, I might just do periodic surveillance cysto, reassure them that the progression rates are low. If on cysto we see increasing tumor burden, then we will go ahead and resect them. But a lot of times I'm observing them and essentially doing active surveillance of some of these tumors. But if they recur frequently, when we do resect them, we will give always perioperative gemcitabine. And then if the patients are really troubled by it and it's really driven more by the patient, then I will do intravesical GEM or intravesical GEM dosing with an induction and then with a maintenance. But we rarely get to that point because I don't see as many bulky intermediate risk tumors for one reason or another.
And Dr. Porten, what's happening in San Francisco?
So probably somewhere in the middle. I think it depends a little on when the patient comes to you in their disease course, right? So if you're making the initial diagnosis of a very large, low grade TA, solitary tumor, maybe a few satellites, you'll discuss with that patient exactly like adjuvant intravesical gemcitabine induction plus or minus maintenance, right, to reduce recurrence and down the road. But if I'm seeing someone who's got a long-term stable intermittent recurrences of low-grade TA disease, they have options available to them. And it's sort of talking to them, okay, well, we can reduce this recurrences. We can see if we can get a longer disease-free interval with using adjuvant therapy, or we could go on a surveillance regimen where I see you every 4 months, 6 months, and we fulgurate in the office. And we kind of go through the decision-making process, what that would look like. For some people, it's time off work. For others, it's financial or the time it takes to drive and park. And so
especially
it's a little,
San Francisco.
Especially in San Francisco.
Yes.
I don't even park, I walk to work. And so I think all those things kind of come into play when you're making these decisions. And I suspect both of you also end up having those same conversations and taking those same things into account.
You alluded to one of the things I was going to ask about. So you said you sometimes do ablations in the office. So when you see recurrent tumors and someone who you've known from the past resection has got low-grade histology, do we need pathologic sampling again? Do we need to take these patients to the OR and get a good specimen for our pathologist? Or can we, you're saying ablation in the office, you're saying maybe surveillance and just watching them grow. What's the value in repeated histologic evaluation?
Yeah, great questions. I think, as has been discussed before, the progression rates are low, and the longer you go out from that initial resection, the more likely they're going to be recurring with that same histology. Every once in a while, you're going to see that great progression. My practice is always to do the biopsy if I'm going to ablate in the office or do a fulguration of a small tumor. I will do a biopsy just to make sure. Probably 90 to 95% of the time it'll be the same, but it's you need to document. We're in sort of academic and learning environments and want to capture the data as well. But more so we don't want to miss those 10%, 5 to 10% potential progression rates, because that'll move them into a different category. So I don't necessarily take them to the OR. If it's a small tumor, if it's been long enough, and we're doing flexible blue light cystoscopy, for instance, in the office, and we can see these tumors very nicely. We've got suction on the device, so it makes it much easier,
nice.
right?
Yeah,
to do biopsies in the clinic. So the use of the Flex Blue has really increased my biopsy rates in the office. So yeah, I'll do the biopsy fulguration of that tumor. Now, whether you want to give adjuvant after that, based on that will be your sort of TURBTs, so to speak, and do adjuvant after that. That's a possibility.
So maybe for people who aren't doing it in the office, maybe Dr. Agarwal, can you walk us through what it looks like to do an in-office, like flexible scope biopsy fulgurization?
Yeah, so essentially you could do it with blue light or without blue light. I do think blue light's very helpful because there are sometimes some really tiny tumors that almost look like the same color as the lining of the bladder, and you can miss it. So I think that blue light helps you pick up those really tiny tumors. But essentially, I'll take the largest tumor that I can biopsy, and I will take that, try to get the whole stalk, and try to get a deep bite below it with a flexible, cold cup biopsy forceps. And once I do that, I might get even a second bite of the base to send that off as well, because there's some data that suggests that you can better stage a tumor if you take a second biopsy at the base. And then I'll take a bug bee and I'll cauterize the base of that. And then the other little tumors around it, I'll cauterize them. And so I try to cauterize all of them. I think what I've also tried to do, if I'm going to do that, is sometimes I might even, once we're done, get them to another room, and then our nurse will give gemcitabine, and then we'll do the adjuvant gemcitabine and then send them out. But I tell the patients, this is like you're not going to need anesthesia, but you're going to be in my office probably for like 90 minutes with doing this and then switching over to that. But yeah, I think it works great. I think if you're going to do it, that'd be the best way to do it.
And you do this the same time you're doing your diagnostic cysto, you see it, you do it right away. You're not bringing them back for this.
Well, with my workflow, I do bring them back on a separate day just because it's a busy clinic. But I think if I planned better, I probably could do it on the same day.
And are you guys using intravesical lidocaine topical anesthetic or nothing?
No.
No.
Yeah. They tolerate it pretty well. These are small biopsies. Technical question. Can I ask you guys whether you bring it through the scope or you take the whole scope out with the biopsy forceps?
So I take the whole thing out because the problem is I have seen loss of that tumor specimen. And then if you believe you're seeding something, it's sort of nice if you have it kind of the scope will kind of create this center channel that'll bring the tumor without sort of scraping it up.
Oh, seed the urethra?
I know, I don't know, but I just sort of bring it out. If it's a large specimen, if it's really tiny, I'll pull it through the scope. But the problem is once you come through the nipple of the scope, that sometimes you can lose your specimen.
Sure.
Yeah. I don't know if you.
It depends on how big it is. I just do it right there if I see it. We have created this little kits that are in the cysto rooms, and so you can easily open it up and have all the things for a biopsy and fulguration in probably they can set it up in about a minute and a half. If need be. If you're doing a lot and if somebody has been uncomfortable from before, we will do intravesical lidocaine for those patients. But I'd say by and large, most patients tolerate it. I think one other key thing is you need the bladder distended, but not over distended. It's really bladder spasms that are probably the most uncomfortable. And if they're all small and I can get it through the scope, if you can not go in and out of the bladder neck often, that also can help with patient comfort. So I think those are the couple things. The blue light's nice because you have a suction device. Otherwise, you'll have to take opportunity to kind of, with a Lurolux syringe, empty the bladder, reset again.
Right.
And that can sometimes be a lot in terms of time, and also cycling the bladder full and empty. That also creates a lot of spasms.
But if I may, which is relevant to further the later discussion, when you have small specimens, and we're in the era of molecular diagnostics, when you have very small specimens that we do these office TURBTs, we're not going to be able to send that tissue off for, let's say, FGFR3 testing because now we have targets. Many of our newer sort of therapies and trials don't include that, but if you're going to think about that, you do need bigger biopsy samples. So it's been a challenge, I think, trying to do molecular diagnostics on small samples.
I have one comment on that. There's a way around it. You can actually make cell blocks from cytology. So at the end, once you've biopsied and done things, there is cells floating around. If you take that as your cytology and send it to your cytopathologist and ask them to make cell blocks from it, you can actually get pretty good FGFR testing from that. We've had some success with that.
That's a nice trick. Absolutely. So you guys talked about gemcitabine as a treatment after these resections. This is in an adjuvant setting. So maybe just to, maybe this is nomenclature, but maybe Dr. Porten, talk us through the principle of adjuvant therapy so that we can move on to ideas of using the same drugs in a different context.
Yeah, so in theory for adjuvant therapy, this is to prevent a recurrence. You're not, I guess you could be a little bit, but you want to sort of time it about, you don't want it to start 3 months after your TURBT, right? You would like to ideally start somewhere between 2 to 6 weeks post-resection when you know your bladder is clear or completely clean. And the principles is to try to prevent the development of a new tumor or recurrence primarily. And so I think that that's like an important principle and kind of goes out a little bit on the timing.
Yeah. And I was trying to tell my patients, the goal here is we've surgically made you free of disease and we're trying to keep you that way. We're not trying to treat anything right now. We're just trying to keep you the way we've gotten you. And I think that's different when we look forward in terms of, newer approaches to using some of the same drugs we're comfortable with. We're trying to actually treat disease that's there. So, maybe Dr. Agarwal, you want to take on the notion of, instead of adjuvant therapy, chemoablation. What do we mean by chemoablation?
Yeah, so there's nice historical studies, marker lesion trials that we were talking about earlier that where you leave a tumor in and you put mitomycin in, and you can see that with sequential mitomycin treatments that the tumor can go away. BCG is not a chemoablative treatment. So for papillary disease, BCG, you actually have to resect all the papillary disease to let the BCG work. But there's a thought that chemotherapeutics, mitomycin, maybe others, can potentially ablate the tumor, and therefore you don't require a resection. So it's been an idea. We talked about it at a lot of consensus meetings on how to design trials. And we've always worried about doing trials with marker lesion studies because of the ethics of leaving a tumor behind and whether patients would adopt that. But and I think that's why it's been slow to explore, because we've always worried about the implications of leaving tumor behind. But there is good evidence for chemoablation, specifically with a drug like mitomycin. And I think now we're exploring that as a community.